Oh, give me 1 second. Hi, everybody. We'll get started in just a second, but go ahead and settle in. Well, thanks, everybody. Thanks for lending us your time today. I think before we dive into the good stuff, there's just a couple of housekeeping reminders. Quick disclosure that the session is being recorded. So in case you have to step away and miss a portion of this, or if you have colleagues who may be interested, we'll be sharing the recording slides and additional resources with you next week. For anyone who needs or likes to have captions, you may enable them by selecting the CC or transcript icon from your Zoom toolbar. The chat feature is enabled, and I encourage you to engage throughout today's session by sharing comments or reflections or questions. You can do that at any time. Just a reminder to please be courteous and kind and lean into the notion that we're all here to learn about LTSS. We're saving time for questions towards the end of the session. But again, you don't have to wait. You can drop them into chat or Q&A at any time, and we'll sort of organize on our end and fire them off at the designated time. And throughout the session, we'll be launching a series of polls. They're just for fun. There's no wrong answers. So when you see poll questions pop up, please feel free to respond, or you can close them out and close out the pop-up by selecting the X in the top right corner. Okay, so onward. Today we gather to talk about long-term services and supports, and Monica, who's with us today, will provide us a little bit more detail on what exactly LTSS is, but in a pinch, LTSS encompasses a range of services designed to support individuals with functional limitations over an extended period of time. LTSS is often associated with older adults, and it's true that prevalence of functional limitations increases with age. But the reality is that LTSS is not age specific. Disability and chronic conditions can occur at any time, and it's just part of the rich makeup and diversity of the human experience. It's crucial to understand that LTSS is just one piece of the puzzle. Aging well is determined by a constellation of factors, from housing policy to transportation, financial security, social connections, access to healthcare. All of these things come together, intersect, ebb and weave into an individual's quality of life. Inadequate housing can exacerbate health issues. Financial instability can limit access to necessary care. And well, we have to think in terms of intersectionality and take multifaceted approaches. It requires collaboration between policymakers and government agencies, healthcare providers, community organizations, and individuals at the receiving end of the delivery system. One of the resources we'll highlight today throughout the presentation is AARP's LTSS Scorecard, which measures states on their movement towards a high-performing system of care for older adults, people with disabilities, and family caregivers. The scorecard uses a ranking system to compare states overall across performance dimensions. California's LTSS system ranks 11th in the nation. We do quite well on some indicators, while there's still ample room to grow on other indicators. So you may hear reference to the LTSS scorecard throughout today's presentation as we talk about the implications for improving California's LTSS. momentarily, I'll drop the link in the chat to the scorecard, as well as a webinar recording from one that we hosted in November that specifically focused on the results from the 2022 scorecard. And with that, I am so delighted to introduce, oh, sorry. I'm oh, thank you. I think we had a screen sharing issue on my end, so I apologize. Thank you for whoever took over. I think that might have been Olivia. And I'm delighted to introduce Dan Oakenfuss, who's the Public Policy Manager at the California Foundation for Independent Living Centers. Dan has a background in working as a legislative staff member, so I know that he is well versed with some of the things that legislative staff members have to do, the experience of that. And with that, Dan, I'm going to pass it over to you.
Great. Thank you so much, Maria. Hi, everyone. My name is Dan Oakenfuss, and I work for the California Foundation for Independent Living Centers. Independent living centers are nonprofit organizations located in most of the major cities here in California, and we provide services and supports for people with disabilities so they can live comfortably in their own homes. And I am happy to be here. I'm a public policy manager for CFILC. We have 25 independent living centers across the state, and a lot of them are in your districts, and we serve over 20,000 constituents throughout in our receiving your services from our ILCs. Let's begin today. We are going to have a wonderful discussion providing an overview of long-term services and supports, what that means in California. We are also going to have discussions on the levels of access to these supportive services, and a deep dive into the caregivers. Who are the caregivers of our seniors and people with disabilities, and what can we do to improve their conditions, improve their livelihoods? And then finally, we get to the billion-dollar question of affordability of this care. How can we elevate, with scarce dollars, the services that we provide for these constituents? And then we'll get into some key takeaways that I'll summarize from today's panels, and then want to leave plenty of opportunity for Q&A afterwards. And so with that, I want to introduce my friend Elizabeth Fuller. She is the Chief Consultant for the Assembly Committee on Aging and Long-Term Care. And thank you for joining us today, Elizabeth.
Thank you, Dan. Again, my name is Liz, and I'm going to actually help us catch up to getting back to where we want to be in the agenda. So I will be very, very brief today. First, I wanted to welcome all the legislative staff that are here. When this was brought forward on what we were hoping to develop for today, I think this is a policy space that is very nuanced and can be brought up in discussions and in webinars, and there's a lot of acronyms used and a lot of different departments that blend and braid funding and programs, and it can get very confusing. And so something that's very intentional today is that the speakers are going to try to speak in a way that will help us all understand what they do foundationally. And then it leaves an opportunity for us to be interested and ask questions and stay engaged. I know that there's a hope that there will be more to come in the coming months on what some of these individual programs do that we can learn more, but also just for all of us to be more engaged for our bosses in this space. If you choose to bring something forward in policy, you have to understand that you are doing something straight out of the gate that impacts a quarter of the constituency in your district. And very few other bills or pieces of legislation will do that. So I think that we need to see the excitement of what a bill in the aging space can do and hopefully move forward with that. I can't really talk about what we need to be doing in this space without acknowledging that we are facing a budget deficit. January came out with kindness in the spaces that impact aging and disability. And I say kindness because there were no significant cuts. There were no program eliminations that can't be borne. but that's a January budget. And we certainly know that analysts have come out and put the numbers of where they believe we are at almost double what we sought our budget to be in January. So we need to be mindful. We need to be mindful that this certainly isn't a year where we are going to see a lot of expansion in the programs that we have, but it's a time to be talking about policy. And it doesn't mean that it's just the policies that are moving now, but conversations around policy in this space can be happening year round. Some will take many years to move forward, but we can be talking about them at any time. I want to say to the legislative staff that are on today that my phone is open, my door is open. Not all offices are equipped to help people gain a strength in the full legislative process. A lot of offices have new staff in all of the chairs that are in their own individual office. And please find ways to reach out, use the advocates in this space. Please bookmark today's agenda, because this is really a brain trust of all of the people that have put in their career in this space, but also within the building. Please always be asking the question about, what does the policy consultant think about this? Or what does the budget consultant think about this? And how can I be more engaged? So I want to thank everyone who will come after me for the work that they do in this space. And I will kick it back to my friend Dan.
Terrific. Thank you so much, Liz. Once again, we're going to proceed to our first panel, and this is going to be an overview of the LTSS landscape. And we're going to have a panel discussion with three panelists: Monica Kirkland, State Policy Director, Senior Services Coalition of Alameda County; Debbie Toth, President CEO of Choice in Aging; and Sawait Seum, Senior Policy Advocate of Disability Rights California. So with that, let's begin with Monica.
Thank you so much, Dan. Yes, so for long-term services, I want to highlight that these are services that include your personal, medical, and social supports. It's really a comprehensive approach to services that addresses not only the medical needs, but their personal and social aspects, really showcasing a holistic approach to care for individuals with both functional and cognitive challenges. And while it's inherent in the name, it's not a short-term solution. It's designed to provide ongoing support, and indeed, it's a necessity. If we can go on to the next slide. So what does this look like? Who uses these? So as you can see, there's personal care, transportation, wounded care. Because every person has unique needs, what you find is an ecosystem of services ranging from what you can see here on the screen to also legal services, congregate dinners when they're offered nutritious meals, not just meals, but nutritious meals, housing assistance, Meals on Wheels, as I know many of us have heard, and the list goes on. These are what I like to call the gap fillers in areas that if they weren't utilized, it would really impact the individual's lives. And so some of the individuals that use these services is the elderly population. It could be individuals with disabilities, chronically ill individuals, those with cognitive impairments. And what's great about this is the better that we understand the diverse range of those that are using these services, and we highlight that importance and tailor these long-term services and supports, it helps to meet the unique needs of each person. We can go on to the next slide. And so if we look at it, you will often see, along with long-term services and supports, it is the home and community-based services. And so a lot of that, you can see, is the personal care, respite care, adult day health care centers. Is provided over an extended period, predominantly in the member's home or community, but it can also be a facility-based setting, such as a nursing home or other institutionalized facilities. And even if we look at the adult day healthcare centers, this is not just a community center that they go to. They're actual nurses on staff that while they are there, they can tend to their needs, their cognitive needs, their health needs, and this also allows for those who are their caregivers to go to work. And so this really helps the entire home unit. So there is a unifying base here that these long-term services and supports provides, not just for that individual, but for the family across the board. And really the goal is for them to maintain a quality of life and to live with dignity. And so I do want to leave you with this example. Mr. M, who was helped by one of the organizations within our coalition. He's a 72-year-old Japanese male who was blind and had health issues. And when they first met him, he was homeless. And he had many challenges along with being unfamiliar with the territory and also having health issues. Well, his case manager helped him with Medi-Cal, getting him set up with in-home supportive services, CalFresh, low-income housing, transportation, Meals on Wheels, a friendly visitor who has now been in his life for the past 10 years. And they worked with him, not just in his in-home supportive services, but the apartment manager, anything that was needed to maintain his quality of life and to help him become stable, that's what they assisted in. And what you'll find now is he is secure in his home. His caregiver has been with him for 5 years, and he has a over 60 health clinic that he is a part of. So there are either Mr. M's who are utilizing maybe 7 to 9 of these services, or maybe just one of them. And so at the end of each of these services, you'll find a Mr. M or an individual who needs to use at least one of these, whose life is impacted by these services if they're not provided. And with that, I will go ahead and hand that over to Debbie.
Hello, everybody, and thank you for being here. And boy, that's an interesting camera I've got going on. Sorry, I wasn't here for visual check. My name is Debbie Toth. I'm with Choice in Aging. I've been with Choice in Aging for 22 years this May, and have a real love for the populations that we serve. You will see the little humans running around in the back. That's our intergenerational Montessori preschool. They hang out with our folks in adult day healthcare, which you just heard about. I'm here to talk about LTSS through the years, or long-term supports and services through the years. So in the early 60s and 70s, our long-term care system was really just about institutional sort of places and spaces. And I think that we saw in the late 70s, early 80s, we were seeing these exposés in the media, like what you saw during the pandemic, about what was happening in skilled nursing facilities. And we knew that this was not the answer to what long-term care should look like. And in 1969, we saw parents storming the Capitol and saying there has got to be something better for our children with disabilities. We didn't have that same kind of advocacy in the aging space, but thank goodness for these parents who came in. The real Fran Smith, if you know her, she was part of the parents that marched over to the Capitol and got legislation passed so that people with developmental disabilities would have access to the same kind of healthcare and services that anybody else in our state had. In the 80s and 90s, we start to see this shift from institutional care to community-based care. And we're not talking yet about aging in place. That's not even a concept at this point, except we know that we don't want to be in institutions. So we start to see Medicaid waivers, which allow us to do, a Medicaid waiver actually allows you to do something a little different than what Medicaid normally pays for. So you get to see us starting to put together things like food and transportation and various different things that will help people continue to live in the community rather than institutions. And then in the late 90s and early 2000s, you really start to see movement toward how do we coordinate? How do we stop being siloized in all these different places and spaces? And how do we coordinate care? We hadn't yet gotten down to the concept of a person being a whole human being and their healthcare being impacted by the color of their skin, the geography where they live, access to transportation, education, nutrition, all of those things. Next slide, please. So in the mid-2000s, we start addressing that. Oops. In the mid-2000s, we start addressing that. And we have this demonstration project that happens at the federal level which is called Money Follows the Person at the federal level. Here in California, we love rebranding everything, right? We took Medicaid, made it Medi-Cal. We took Money Follows the Person. We made it California Community Transition. But there's a whole list of them. But anyway, we started looking at how do we get people out of skilled nursing and move them back into the community. And once we've done that, we actually save a ton of money. And wow, guess what? People are happier. They're more joyful. They're getting to live in community. And we also saw that the state was like, we still need to coordinate better. This is not enough. We've still got silos. So they launched this thing called the Coordinated Care Initiative to try and bring together Medi-Cal and Medicare and coordinate care better, because we don't appear as human beings in separate places and spaces. We are one human. So that didn't really get where we needed to get. There were a variety of reasons for that, but the intention is there. So in 2021, we see the release of the Master Plan for Aging, and I will tell you that all of the people presenting today, that was our symphony. There is a Master Plan for Aging, and by the way, when the disability population and the aging population got married through this process, it was the most beautiful marriage for which there will not be a divorce. I won't say that we're perfect and we match in every way in space, but we are an incredible, beautiful partnership. And we're here today because you have told us, and your predecessors in the legislature and in the staffing have told us, stop coming to us as siloed, fractionated people, come to us as one unit. And that's what we are through the California Collaborative for Long-Term Services and Support. So you're welcome. And then CalAIM is launched, and CalAIM actually brings home what we didn't have with just the Coordinated Care Initiative, which is we recognize the person as a whole person. We recognize that transportation impacts health, food impacts health, access to friends and social resources, all these things. So the promise of CalAIM is there. We need the funding and we need to keep our programs whole. Next slide, please, because we have this massively growing aging population. Fun fact, there are more people turning 65 years old this year than in any other year in our history. By 2030, 1 in 4 Californians are going to be 60 or older, and 1 in 4 Californians live with a disability. We need to do better. We need to dedicate more funding. We need to ensure that our budget, when we look at the budget, when we plan for the budget, that we plan for this huge chunk of the population. You don't have to love old people like I love old people, but you sure as heck better start planning for them because they gained 3 decades of life expectancy last century that we didn't plan for. So really, that's what we want to partner with you on. And I am going to hand it over to my colleague and my friend, Sawait. Take it away.
Thank you, Debbie. Good morning, everyone. Welcome. My name is Sawait Siem, and I'm one of our senior policy advocates for Disability Rights California. It's really great to be here with you all. And just following Debbie, my colleague Debbie here, I want to just spend a few minutes to talk about the vision for LTSS and what that looks like, a collective vision for LTSS really. As Debbie just shared, by 2030, 1 in 4 Californians will be age 60 and older. 1 in 4 Californians live with a disability, and the number of older disabled Californians will increase by 160% between 2015 and 2060. And so the growing demand for improved access to care, delivery of services is evident. And I would say, when we talk about a collective vision for LTSS in California, we really have to begin with a conversation about health equity. Many discovered at the peak of COVID what many of us had already been experiencing for decades, and that is that there is an inequitable distribution of services and supports within the healthcare delivery system, and in this case, within the LTSS system. The data is clear throughout California and also really nationwide. Really, older adults and persons with disabilities face ongoing inequities in health outcomes and access to services. And there have been valiant efforts to address the inequities, but
we note that many of those efforts have been fragmented and siloed, and many have fallen short. And since COVID, we've seen such an increase in these efforts, and we want to recognize these efforts, including from our governor and our state lawmakers. But really, in order for us to arrive at a collective vision for LTSS, we must continue to center our conversations around health equity so that we can address the inequities that currently exist and persist in aging, disability, and racial and social justice systems. And I'll also just add, second, a collective vision for LTSS. We must continue to center the voices of those most affected at the center of our advocacy. At Disability Rights California, we really strive to ensure the voices of those with lived experiences are at the center of our advocacy efforts. And I think that as I close here, as we continue to center our work around health equity, the principles of health equity, and we continue to center the voices of the most affected in our advocacy efforts, truly, this is when we will begin to realize the collective vision that we have for LTSS, where the principles for an equitable and high quality system of care are realized. Thank you. And with that, I will pass it back to you, Dan.
Great. Thank you, everyone. Now we'll move on to our second panel, which is about navigating the LTSS system. And with me today, we'll have two panelists. We'll have Lydia Miselides, Executive Director, Alliance for Leadership in Education, and Interim Executive Director of the California Association of Adult Day Services. Followed by Lydia, we'll have Michael Costa, Executive Director, California Association of Area Agencies on Aging. Thank you. And Lydia, you may begin.
Thank you, Dan. Hi, everyone. I'm Lydia Miselides, as Dan said, and I've been laboring as an advocate in the aging and disability space for more than 30 years now, so can proudly now call myself an older adult, and I also happen to be a caregiver in both of those spaces. As Debbie hinted, over the decades, bookshelves have been filled with reports and studies about the fragmented system of services and supports for people who need and desire such supports outside of an institution. And countless legislative prescriptions for how to solve this problem have also been offered up. It's been decades. This is even as people who advocate for and provide services in our fragmented system work mightily each day to break down the barriers on behalf of people they serve. Finally, system changes are taking place. You'll hear a little bit more about that in a second, but not fast enough for some and a little too fast for others, but that's a discussion for another day. It turns out today, California is in the midst of changing the fifth largest economy in the world to one where our health and social service system break down barriers between health and social services, which, by the way, as you may already know, are composed of government, nonprofit, and for-profit entities. We're trying to transform that to an ecosystem that makes sense and that embraces both health and social services in service of the person who needs those supports. As Deb said, humans are social creatures. We rely on one another for survival and well-being. So people who need services to support their health and well-being and independence are not a diagnosis. They're not a condition. They're not a label of any type. Yet our systems are set up to support people in need, usually designated along these very lines. So for example, I'll give you a couple examples. Age. For example, people age out of the educational system that has met their diverse needs with extra support for their whole childhood. And the transition then to adult services can be really rocky and disruptive. Area agencies on aging are limited to older adults. Sorry, federal rules, you can't change that. There's a lot of other examples about eligibility rules, and no one person, trust me, can possibly know them all. So don't feel bad if you if you don't understand even a few of them. Diagnosis is another category, right, that continues to perpetuate these silos. For example, one of my favorites, counties are responsible for mental health services unless the person has a diagnosis of Alzheimer's disease, which happens to be carved out as not being a mental health condition, even though it is a brain disease, and even though the person exhibits psychiatric symptoms that require professional evaluation and treatment. Never understood that one. And the state bears overall responsibility for mental health in the Medi-Cal system, although Medi-Cal managed care plans recently became responsible for certain types of mental illness, behavioral health in their membership with the rules that are established by the state. So you're getting the picture. I could go on and on with other examples. People are not categories. We have complex and rich histories, lives, and challenges that are unique to all of us. So we're really trying to now move to a more person-centered approach to helping people live their best lives. So I want you just to take a minute, think about your own life experience. If you've had your own family member, you know someone who's experiencing a sudden or lifelong complex medical, physical, behavioral, developmental challenge, how much time is spent figuring out what services, where to get them, are they even available in your zip code? Then maybe you've sorted that out, you realize you've only just started to proceed because you need to know eligibility. Who's eligible? What does it cost? Who pays for it? How long does the service last? Is it temporary? Is it ongoing? Well, perhaps you've sorted all that out. Thank you, internet and artificial intelligence. Now you start to apply for what you think you need. You may or may not qualify for that service. Next, you need help. You realize you need help coordinating those services, and you probably need help making appointments, getting to the appointment. In other words, transportation, keeping hold of your housing, getting medical supplies, medications, and so on. And then don't forget to build into your timeline of coordinating all this that you may have rejected applications, lost applications, refaxing documentation. Yes, faxing is still a way of the world in Medi-Cal. And that is what starts you down this path of attempting to coordinate care when it becomes a crisis of care. It becomes a crisis that could land you in the emergency department, hospital, and maybe even a nursing home stay after that. And hopefully you don't get to stay too long in the nursing home so that you don't lose your housing while you are there. So just trying to paint a picture of a scenario, but I also want you to add into that now the complexity of language and cultural barriers that lead to poor communication, racial disparities in access to nutrition, jobs, education, transportation, things we now call social determinants of health. And the result is inequitable access to care that is really hard to navigate. So if you're lucky in this journey, you've connected with a care coordinator, maybe with some vast experience who can help you. Maybe not. Maybe you're alone in the world with no family or friends, but you need help. What becomes of you? So as I said earlier, it's been decades in the making, as you heard from Debbie, but California is finally beginning to see some progress on breaking down these silos of care. It's slow and hard work. Michael Costa, who's coming up next, will share where we are today in defragmenting these silos of care. It's definitely a work of progress, and we're all learning together. Michael.
Thank you, Lydia. I'm Michael Costa. I'm Executive Director of the California Association of Area Agencies on Aging, otherwise known as C4A, because there's far too many words. I represent and lead a trade association representing the AAAs in California, who are really established in 1973 as an amendment to the Older Americans Act, as providing kind of the funding and governance and flow through channeling for federal fundings under the Older Americans Act for LTSS services. And there are now 33 AAAs in California that cover all 58 counties. And many of the AAAs provide a range of services, LTSS services, but also in some circumstances, they will contract out with a range of community providers, such as meal programs. So it's sort of essential. I guess it's useful to think of AAAs as sort of the skeleton by which many LTSS services are actually provided in California. And one of the things that we are very kind of involved in right now is something called the Aging and Disability Resource Connection, otherwise known as ADRCs. I'll use that acronym once. And they are basically organizations that are set up as a partnership between a AAA and an independent living center to provide a range of services and resources that actually allow an individual to connect with the delivery system. And it's the aging delivery system, it's a disability delivery system. And the services can be informational and referral. They can be some case management, some options counseling, and care coordination for short term. So it's really intended to be a comprehensive entry point into the delivery system. Now, it is a principal component of what the Master Plan on Aging envisions as a no wrong door system. And currently, there's an amount allocated every year for funding for that, and we need to kind of expand the amount of funding. And we're working this year with the legislature to do that. I know it's a tough year for a budget ask, but in order for a full statewide ADRC system to exist, and thereby a component to the no wrong door system, we really need additional money to do that. So I'm mentioning that in passing, but you'll all hear more about that this year. Now, besides the ADRC systems and the no wrong door system, another way of really realizing the Master Plan on Aging is through looking at the system and what the system should really look like and be in 2030, a few years down the pike. And so over the past year, the Department of Aging had put together a committee of stakeholders from throughout California. We were one of those participants on that committee, and they developed kind of initial vision for what that system could look like in 2030. And the traits of the system would be that the network, the aging network, delivery network, would be aging and disability forward in that it understands, prevents, and combats negative stereotypes associated with aging and disability, that it's inclusive and equitable and addresses ageism, ableism, racism, and implicit biases, that it's well-known and accessible, so it should be accessible to all Californians, and that it's consistent in the sense that it provides a reliable standard of quality and core services across the state, that it's locally responsive, that it's strategic and action-oriented, and that there's a performance and outcomes-based evaluation system just to be able to show the impact of the services and by measuring and monitoring performance, and demonstrating that there are social, health, and economic outcomes that are benefit of Californians, and that it's integrated. That as Debbie mentioned earlier, and Lydia did as well, you really need to have a system in place that integrates social services and healthcare for an older population and individuals living with disabilities. So that's the kind of vision of what the network should look like. And that resulted in a number of recommendations being made that the department is currently kind of mulling over in terms of how those will be realized. But the department's looking at a whole range of areas around funding, services, communications, designations for AAAs, performance, data information technology, workforce, and advocacy. So the recommendations are included in a report called California 2030. I urge you to have a look at that report. It just came out in January. And in order to actually increase access and availability, we also have to understand where the gaps are in the system. So the Department of Aging has commissioned Mathematica, an outside consulting firm, to conduct a home and community-based service gap analysis to examine the gaps and trends in HCBS services that are not funded by Medi-Cal in California. This gap analysis will inform the development of a multi-year roadmap to advance non-Medi-Cal HCBS infrastructure, and it's an initiative under the Master Plan on Aging. So it's one of the recommendations that's being realized through actually undertaking the gap analysis. Now, this work actually intersects with a similar gap analysis that Mathematica is conducting in partnership with the Department of Healthcare Services, and that is focused on Medi-Cal covered HCBS. So at the end of these two analyses, we should have a good idea of where the gaps are, both for the non-Medi-Cal and the Medi-Cal population. So Mathematics is conducting interviews with a number of providers in the system over the next few months. And it will also be conducting a range of interviews with subject matter experts to learn really more about where we are and where we should go in terms of addressing the gaps. So then finally, I want to mention briefly that the Older Californians Act, which we have in California and a lot of states don't have, actually augments the Older Americans Act. And so it provides for a range of LTSS services, the funding for it, as well as the delivery of the services. And we at C4A are actually, along with CFILC, are actually sponsoring a bill that's just been introduced. It's AB 2636, and that's really looking at the modernizing the Act, Older Californians Act, to reflect the current environment we live in. It hasn't substantially been amended since 1997, so we really want to bring it up to where we are now. And part of that is really to look at the scope of that act, because that's really that really informs policy development, aging policy development in California. So you will also, those of you who are legislative staff, will also be hearing more about AB 2636 going forward as well. So as you can see, there's just a lot of efforts going on in different ways to realize the Master Plan on Aging and to really look at improving the delivery system, all with a frame toward increasing access to services going forward. So with that, I think I'll turn it back to Dan.
Great, thank you so much, Michael. That was a very engaging panel here on the access and the levels of the varying levels of long-term service and supports. Now we're going to shift to the humans that are behind this system, and this is the caregivers. And I'm going to introduce our next two speakers for our third panel. Nina Weiler-Harwell. She is the Associate Director of Advocacy and Community Engagement at AARP California, and then followed by Amber King, Vice President of Legislative Affairs for Leading Age California. And Nina, take it away. Nina, you're
muted. Oops, let's start again. Good morning, and thank you so much for joining us today. I see we have a nice size audience, so really appreciate your attention to these just critical issues for older Californians and individuals with disabilities. So we'll just start with the basic facts about caregivers in California. And the data that I'm going to share comes from a couple of sources. I will tell you what they are. But first of all, ARP's Valuing the Invaluable Valuing the Invaluable 2023 update found that there are 4.4 million family caregivers in California. And this is specifically caregivers for people 18 and over. So it doesn't include caregivers of children. That number would be higher. Various studies have shown that women, and especially women of color, are providing a disproportionately large share of unpaid caregiving or family caregiving, often while also caring for children and working. So these are the sandwich generation caregivers that we hear so much about. In addition, 67% of California family caregivers use their own resources to care for a loved one. And I believe that data comes from the caregiver resource centers. Finally, I'll just talk about what's on this slide, and then I'm going to hit a couple of other points. Also from Valuing the Invaluable, California caregivers provide $81 billion annually in economic value. They contribute 4 billion hours of unpaid care. So what ARP did was actually look at what the going rate would be if they were paid. And that's how we got to the 81 billion. But family caregivers do provide the bulk of long-term supports and services for Californians who need assistance with activity, not just activities of daily living, but sometimes often medical tasks at home. I want to highlight one other thing, and then we can go to the next slide. Also, according to AARP's cost of caregiving study, the average family caregiver, this is nationwide, spends over $7,200 a year out of pocket to care for a loved one. It could be, installing a ramp, taking them to and from appointments, buying them food, helping them to transition to assisted living. My brother paid $10,000 out of pocket to move our mother into a continuing care retirement community when her health began to decline. So that's a massive amount of money that's going to force families to choose between food, other amenities, maybe have to move to a cheaper location in order to cover those high costs. So I'll go to the next slide. But in the last few years, we've actually had some exciting wins and one issue that we continue to push for. Since 2019, we've had several expansions of family leave. Most of these are in the realm of paid family leave, so I'm going to start with that first. In 2020, the legislature approved and Governor Newsom signed a bill to finally expand paid family leave to employees of firms of 5 or more. Prior to that, it was aligned with FMLA, which is 50 or more. That means the vast majority of working Californians could not access the benefit. During this time frame, right before that, we also expanded paid family leave to include military exigency leave. So that would be for a family member who has to make a lot of arrangements for their family and for the individual that they're living with to deploy overseas. So there's a lot of work that goes into that. Someone is in the military serving our country. They are deployed overseas, and another family member steps in to assist with making all the arrangements that need to be made, like finding childcare or other matters that might be needed. Under just family leave expansion, 2 years ago, we passed legislation to allow family of choice caregivers to take unpaid but job protected leave. So that's why this is not paid family leave, it's just family leave. So if you're a family of choice caregiver, you can take advantage of that, but you're not eligible for paid family leave under that situation. I'll move on next to a really exciting development from last year. This was one of ARP's, well, all these bills were ARP priorities, but paid sick leave expansion was our biggest priority last year, as it turned out. And what we finally did after, I think, 4 attempts is increase paid sick leave for working Californians from 3 to 5 days. And if you're not familiar with the program doesn't just cover the person who's sick, it covers the family member, a close family member, who needs to take off time to care for the person who has COVID, flu, RSV, which my family recently experienced. It also allows for that person to also assist with other issues around stalking. So it was a really good expansion. Again, we went from 3 to 5 days, and that was effective January 1st. I'll now go a bit back further in time to the Hospital and Family Caregiver Act. This was actually passed, I may be getting my dates wrong. I think it was 2015. Senator Jackson was the author, and what this did was implement a nationwide ARP model bill in California. So under California law, what's supposed to happen is if your loved one is checked into the hospital, they're supposed to ask who the family caregiver is. They are supposed to give you updates on their discharge plans, and if any medical tasks come home, there is supposed to be hands-on training. So they're not going to just send you a sheet saying, oh, here's how to set up tube feeding, or here's how to check on a catheter, or here's how to do wound care. They're supposed to actually give hands-on demonstration. So again, that's been in effect for quite a few years. One thing that we've been fighting for is a caregiver tax credit. Yes, we know, not this year. We are trying to get a caregiver tax credit enacted so that individuals who pay out of pocket to care for a loved one can actually claim a credit on their state taxes. And we've introduced, I think, 4 bills. I will admit, it's a costly proposal, but we're not going to stop fighting. Oklahoma just passed one, so let's see, when California is ready to take that on. But essentially, what the credit does is the model law is up to $5,000. If you spend $5,000 out of pocket on a loved one or more, you can claim a credit, or up to $5,000. And it's 50%. Anyway, I won't go into all that other detail, but it would also cover the bills that we introduced did also cover costs of caring for children or younger loved ones, as well as older loved ones. With regard to caregiver respite and training, we actually do have some initiatives that are already effective in California. So first of all, shout out to our caregiver resource centers, who provide respite, provide training, financial and legal counseling, and are just an incredible resource for connecting many of our members to home and community-based services. What's great about their program is it's not income-based, and you don't have to be 65 and older to claim it. You can be younger than that. There's also a caregiver respite and training program, or caregiver respite program, called the Family Caregiver Support Program, that's operated through the Department of Aging. That is income-based. It's a fairly small program, but something that people might want to explore if they are seeking caregiver respite and they themselves are low income. I will also mention one other program that I know provides caregiver respite, because we got to take advantage of it. If you are a regional center client, our son has autism. While that individual, I'm not aware of the adult services, but I do know that up to the age of 13, Alta Regional gave us respite care so that we could take a break. And somebody who actually knew our son really well and loved him could just come in and spend time with him while my husband and I went out and did other things. So that's the end. That's what I have to share with you today, and happy to take any questions at the end.
Okay, great.
Good morning, everyone. It's nice to be here with you today. I'll be discussing the direct care workforce. As noted on the slides, direct care workers work in a variety of settings, including private homes, community settings, and congregate facilities. 80% are women, 47% are immigrants, and 75% are people of color. Their median income is between $14 and $18 an hour, and 47% receive public assistance. Next slide. The direct care workforce is at a critical point as we are seeing significant shortages in all settings. The need is dire. By 2030, as you've already heard, 1 million plus Californians will have self-care limitations and need some form of care. Also, as you heard from Mina, families are overtaxed and less caregivers will be available to care for those older adults. Older adults and those with disabilities are increasingly preferring to age in place. I know we're seeing that among our members as well. This type of work is demanding physically and emotionally. Coupled with the low wages paid and limited resources available, recruiting and retaining this workforce is a significant challenge. Next slide. Solutions must be multifaceted and long-lasting. In recent years, the state has invested billions of dollars in workforce development programs and grants to grow the workforce with a large focus on healthcare. Unfortunately, the governor's January budget does propose to defer $150 million of this workforce funding. And that action could have very negative consequences, with the onslaught of older adults needing care expected to significantly rise by 2030. I'll also add that Leading Age California has been fortunate enough to receive some of the state's workforce funds through grants, through 3 different grants actually, to train CNAs, home health aides, and healthcare social workers. These programs have been extremely successful so far, exceeding all goals set. More work is needed, though, to continue to grow the workforce, including the full career ladder focused on older adults, including RNs, LVNs, and MSNs. In addition, there is an opportunity to advance program sustaining rates in all long-term care settings to ensure providers have the resources they need to attract and retain high-quality staff, including wage and benefit increases, education and training, and career advancement opportunities. Thank you. And with that, I'll turn it back to Dan.
Hi, thank you very much, Amber. And we will now proceed to the 4th panel of today's webinar. This is going to focus on the affordability of care. And with me today will be Megan Burke, Program Officer, Policy and Advocacy at the SCAN Foundation, followed by Tiffany Wen Cho, Director of California Medicare and Medicaid Advocacy with the Justice and Aging. Thank you so very much. And Megan, take it away.
Thank you, Dan, for that introduction. Again, yes, I'm Megan Burke with the SCAN Foundation, and we work to ignite bold and equitable changes in how older adults age in both home and community. And I think we've heard through this almost an hour from all of my esteemed colleagues how important long-term services and supports is to supporting older adults and people with disabilities aging well in community. But the cost of long-term services and supports varies widely by service and is often out of reach for most older Californians, people with disabilities, and their families. So according to the 2023 AARP Long-Term Services and Supports State Scorecard, home care costs equate to 80% of the median income of an older middle-income household, ranking California at about 19 amidst other states. The annual cost of a nursing home stay is 235% of median income, putting California at about 35 amidst other states. A recent study conducted by NORC at the University of Chicago showed that excluding home equity, 89% of middle-income older Californians will not be able to afford assisted living by 2033. And even if they sold their homes, half would still be challenged to afford assisted living. Next slide, please. More often than not, people think that Medicare will cover the cost of most long-term services and supports, especially those non-medical services. And that is just not the case. And often people find that out way too late. We also know that in California, there's only 4% of Californians that have long-term care policy. So this really, the reality is that Medi-Cal is the primary payer for long-term services and supports in California and nationwide. But accessing Medi-Cal as a public LTSS system requires people to be low income. People with higher incomes can pay out of pocket for their needed services. But people that fall into the middle income population, people that the foundation refers to as the forgotten middle, have too much income to qualify for Medi-Cal and not enough resources to pay for the services that they need. Again, we partnered with NORC at the University of Chicago to look at the forgotten middle here in California. And what we found is that by 2033, 60% of the forgotten middle will be unmarried, divorced, or widowed. 43% will not have children living nearby. And we just heard from Nina about family caregivers. We know that family members, including those spouses and adult children, provide most caregiving for older adults. So older adults who are unmarried and those without children nearby may not have the unpaid sources of care that others might be able to depend on. In addition, the SCAN Foundation has supported work to better understand Californians who are near dual eligible. So those people who have Medicare, but they're just over the income eligibility for Medi-Cal. The research found that 1 in 8 Medicare beneficiaries, mostly people of color, are near dual and have similar health needs as those who are Medi-Cal eligible. So these Californians comprise the lower end of the forgotten middle spectrum and represent really a vulnerable population with complex health needs that are currently without options for paying for the services that they might need to age well in community. As I believe Michael spoke to earlier, the issue of affordability has been long explored in California. And again, in recent years, the master plan for aging prioritized looking at affordability, and the state has taken those steps to gather the data and understand the gaps. Again, as Michael had mentioned, through the home and community-based services gap analysis. There's also been consideration for a public long-term services and supports benefit through Department of Insurance's long-term care insurance task force. Taking action on any of the recommendations that were brought forth by this task force, we wouldn't really see immediate effects, but taking action today would benefit nearly 11 million older Californians who would likely need the services in 2060. Time is of the essence, and there's no real one-size-fits-all at the moment as a solution to address LTSS affordability. It's going to require multiple approaches to meet the needs of older Californians, people with disabilities, and caregivers to really support aging well in community. I think we don't have the time to go in great depth, but some of those options could include exploring a state partnership with Medicare, looking at models of care that integrate housing and long-term services and supports, exploring options that support people with disabilities who are employed but aren't able to access the range of services available in Medi-Cal, such as increasing income eligibility for the Medi-Cal Working Disabled program. And then there's eventually the public long-term care insurance option. I think in future meetings, we can definitely spend time taking a deeper dive into I think options for financing long-term care. It's complicated, but worth the time. And now I'm going to hand it over to Tiffany to touch maybe on some of the Medi-Cal options.
Megan. Hello, and great to see you all. For those that aren't aware, Justice and Aging is a nonprofit advocacy organization working on behalf of low-income older adults. So today I'll provide an overview of recent efforts to increase the number of people eligible for Medi-Cal in order to address the affordability crisis of long-term services and supports. As Megan mentioned, Medi-Cal is the primary payer of long-term services and supports in the nation and in California. Medicare is the federal health insurance program, but it's not free and it's not comprehensive. It does not pay for benefits that keep older adults at home long-term, unlike Medi-Cal. So Medi-Cal really is the primary public vehicle today for accessing long-term services and supports. I'll cover 4 specific Medi-Cal changes today, or expansions, as they are often called. In the past 4 years, there have been significant wins to expand the eligibility criteria in order to qualify for Medi-Cal. Expanding access to Medi-Cal by making it easier to qualify is one strategy to address the affordability crisis. Medi-Cal is a needs-based program, and it's generally free to those who qualify. Historically, to qualify, you had to have limited income and limited assets. Assets were also called resources. Income is the money that someone receives each month, such as employment wages or Social Security retirement. And assets were also considered. Medi-Cal would count someone's cash savings. They would look at their bank accounts or life insurance policies to determine if they were low-resourced enough to qualify for Medi-Cal. The asset limit was low and prevented people from having the adequate resources to weather a crisis, such as an eviction, or even keep an emergency fund. And in contrast, younger adults on Medi-Cal had more generous income limits. They also did not have to prove their resources. So to illustrate what the income and asset limits used to be for older adults over 65 and people with disabilities, in 2020, a single person had to have monthly income below $1,294 a month and $2,000 in resources, less than $2,000 total in your bank accounts and your savings, cash that you had in a mattress. In 2020, the income limit for older adults was increased to 138%. So now older adults can be on Medi-Cal with the same financial limits as younger populations, which today is about $1,752 a month. And recently, just as of January 1st this year, Medi-Cal no longer counts assets or resources. People can save in excess of $2,000. So older adults and people with disabilities no longer have to spend down their resources to qualify for Medi-Cal and access those long-term services and supports that have been covered today. Approximately 12,000 people have become newly eligible because of this change. There is also work that's been done to reform Medi-Cal's share of cost program. The share of cost program impacts the hidden poor or missing middle group whose income is too high for free Medi-Cal, but who can't afford to pay for long-term services and supports out of pocket because of its high costs. Share of cost works very much like a monthly deductible. You access Medi-Cal by paying this deductible monthly if you need services. But because of how the deductible is calculated, older adults are expected to live off $600 a month for their living expenses, which is not feasible for many people. In 2022, a bill was introduced to fix this program to make it more affordable. The bill was included in the budget with implementation set for next year in 2025, but subject to budget appropriation this year. If ultimately implemented, the proposed fixes would lower that monthly deductible so that people can more easily pay it and access Medi-Cal's long-term services and supports. So the share of cost program, the fixes would directly benefit that missing middle population who right now cannot qualify for free Medi-Cal. And through CalAIM, there's been efforts to address homelessness among older adults. There are new Medi-Cal services that address non-medical social needs like housing or food insecurity. One of the goals of CalAIM is to address these non-medical social needs that impact a person's well-being and health. And in just one example, Medi-Cal can now help people obtain and maintain housing. Medi-Cal can help people with securing housing by paying for security deposits or utility fees. Stable housing is needed for many older adults to access Medi-Cal's home-based long-term services and supports. And then lastly, long-term services and supports still remain unaffordable for many low and middle income people. There simply isn't a lot of public financing options for long-term services and supports today. So Justice and Aging and others are engaged in this work, however, and exploring options for expanding Medi-Cal to cover this hidden poor population that earns too much to access long-term services and supports through Medi-Cal. And with that, I'll turn it back to Dan.
Well, great. I want to thank all of our panelists today. We're going to get to some Q&A here, but first I want to comment on some of the takeaways here of today's webinar. We first began with kind of addressing everyone's familiarity of long-term services and supports. So we learned it's multifaceted. There are different levels of services, supports depending on the individual's needs at home, in their community. With the aging and long-term care systems we have here in California, we took a brief overview of the history of this network of care and evolution from how it's been like large state institutional facilities to community care to in-home residency of individuals receiving care at home. Then we got into the challenges of access to LTSS. How to leverage LTSS across the state. Geographically, urban, rural, northern and southern California, and socioeconomically, and how we can create a level that is beneficial for everybody here. We talked about some state initiatives to provide a high level of guidance and strategy to delivering LTSS across these gaps, especially the Master Plan Aging, which involves so many of the wonderful agencies on the state level and local level that help set the standards and deliver these standards. And finally, then third panel, we got into a deep dive in caregiving. Who are the people that are providing these services and supports for our aging and disabled populations? We talked about the wonderful human beings. Usually there could be loved ones in your own home who are trying to keep the care going for their family members. We talked about ways to increase the caregiving community by incentives to make caregiving more affordable for the caregiver themselves. Also, how we deal with very low wages and high burnout among caregivers. And then how can we train and inspire the next generation of caregivers? These are some huge challenges here. There's a huge deficit to overcome here. And finally, in the fourth panel, we got into a lot of the questions of the affordability of long-term service and supports. It's very expensive. You have different levels of LTSS, whether it's adult daycare or home health aides in your home, whether you move up to assisted living, and then on to skilled nursing facilities. Each has a higher level of specificity and skilled workforces, and also higher price tags on those. We looked at affordability of healthcare from individuals who are challenged because they're in the missing middle. They can't qualify for Medi-Cal, but in order to get down to what state benefits provide, they have to spend down their assets to become eligible. And finally, we kind of ended on a high note here about there's a lot of hope and there's a lot of great progress we've made on expanding affordability of LTSS in California. We've looked at legislation and passed legislation that expands income limits and also the amount of assets an individual needs to spend down to qualify for state care and federal care. And then cost sharing, how much can be provided by the caregivers and the family members and the communities of our aging and long-term care populations and disabled populations. So It's a lot to digest in an hour and a half here, so I really appreciate everyone's attention, and I hope you come away with some great insights on the enormity of what long-term service and supports means for Californians. And we have some of the best and brightest on these panels here to help kind of guide you through that today, and not just today, but we'll have information available for how you can contact us afterwards, because when these bills pop up or budget programs pop up, you might want to need to get some more subject matter expertise. So with that, I'm going to open up some questions here. We already received a number of questions from our viewers, so really appreciate that. Let me begin with the first one here. This is directed to Lydia, and it states here, ADHD reimbursement and pay for those not on Medi-Cal is very frustrating. Has there been any discussion about extending these programs for those who don't qualify for Medi-Cal?
Great question. Thank you for the question. Adult day health care is designed as a Medicaid benefit to be an alternative to nursing home. So by that design, the vast majority, probably 98% on any given month, are people who are low income and on Medi-Cal. Private pay individuals are certainly welcome and can access this, but it is not paid for by any other insurance company other than if you happen to have long-term care insurance. Financing for this by another source for people who are not eligible for Medi-Cal would likely be if the state were to proceed with a new long-term care insurance benefit that would include people who are above the Medi-Cal eligibility limit. So I'm afraid I don't have a better answer for you right now. There's been a dream that Medicare would pay for this someday as part of its benefit package, but I fear that that is also a very long ways away. Anything anyone wants to do to advocate for any of those things, please give me a holler and I'll put you in touch with the right people. Thank you.
Okay, thank you very much. Next question. Could be addressed by any of our CalAIM experts here. But how is CalAIM working to address systems fragmentation for Medi-Cal eligible older and disabled adults? Anyone want to take that one?
Could you repeat that, Dan?
Sorry. How is CalAIM working to address systems of fragmentation for Medi-Cal eligible older and disabled adults?
I can try and take a stab at it. This is Debbie Toth. I am no expert by any stretch of the imagination, but I will say that the primary goal, or one of the primary goals of CalAIM, is to reduce that fragmentation by providing what's called enhanced case management, so that a member gets connected to a human being who helps them navigate the system and connects to the different community supports and the services that are provided by the health plan. So it's almost like they have their own personal Julie McCoy. For those of you who are a lot younger than I am, you won't get that reference, but from the Love Boat, that, you know, somebody comes in, they recognize this person, they interview this person, they get to know this person, they connect them to the things that they need to be connected to. So I think that the design is intended to do exactly that, is to break that fragmentation. Now, implementation is another story, and you'll have to come back for another 2-hour webinar on that.
Great. On that note, there's a next question deals with adult day healthcare programs. How do we expand adult day healthcare, including meals and transportation for the missing middle? Who'd like to take the adult
I'll take
day
that,
healthcare?
or Lydia can take that, or we can tag team on that, but that is a fabulous question. So the missing middle is that population that we forget about. So extremely wealthy people can afford the services they need. If you're on Medi-Cal, you have a long-term benefit so that you can get the services that you need. If you're anywhere in between, you cannot afford to get the care that allows you to continue living at home. So how do we get affordable adult day healthcare for people who are in that missing middle, is by ensuring that the rates that we reimburse adult day healthcare centers cover their costs to keep their doors open, because many of us actually provide scholarships to people who cannot afford those services. At Choice in Aging, we don't ever want to turn anybody away because they can't afford our services. So we do fundraising events. We apply for Title III grants through our area agency on aging. We ask our community to help fund scholarships. So there's a lot that we can do, but we can only do that if we get paid a sufficient rate for the people that we do serve. So to me, the rate issue is fundamental to the question. I don't know, Lydia, if you want to add more.
You said it all.
Next question is, given that we're such a diverse state in California, what about culturally appropriate programs for LGBTQ seniors, monolingual, non-English speaking communities, etc.? What kind of resources do we have to serve those communities?
Is it specific to adult day healthcare or?
This was kind of two-parter on the adult day healthcare. What kind of maybe you could touch on some of those programs that reach out to those populations.
So I think it's a very important question. We have a Russian speaking program at Choice in Aging. So mostly serving folks from Russia and the Ukraine and surrounding region. We have a program that is Farsi and Dari. So women from Afghanistan and Iran come to that program. We have a mid to late stage Alzheimer's program. It's possible for us to create programs if we have sufficient funding to be able to serve these populations, because as we age and as this nation grows and as California grows, we are diverse, more and more diverse with the aging population. We don't do a good job with LGBTQIA. There are some fantastic housing programs in San Francisco, but we need to do a ton more work on the LGBTQIA population as a general rule in long-term supports and services. And I think Michael Costa.
Yeah, let me jump in on that particular. Thank you for the lead in, Debbie. If I can kind of talk to the LGBTQI, et cetera, population, there are groups, a national group called SAGE, which manages some cultural competency training programs that our AAAs have used across the state to help educate staff to really be more sensitive to issues around LGBT culture. There's also in San Francisco, there's Open House. I know they also do cultural competency training. I believe the LA LGBT Center does as well. So there are other organizations. And I think the issue is sort of for C4A, we're happy to sponsor and facilitate those sessions. I think, and then when you have something like SAGE, they're willing to do it for free across the state. And I think the issue there partly is just getting the word out to a variety of providers that this resource is available, and then the local provider can decide if they want to take advantage of that.
Perfect. Thank you, Michael.
Can I add one quick thing to that,
sure.
Dan? It has to do with the workforce. So something that hasn't been discussed yet, and that is that as the workforce in our community-based settings has to now compete for wages with higher paid entities who can pay a higher wage, and there's particularly a demand for people who are bicultural and bilingual. We're finding in the community setting that it is harder to recruit and retain staff that have those language and cultural skills. And that all goes back again to Debbie's point about inadequate rates. And so we have to really continue to quickly and diligently address the workforce crisis that we're all facing right now in the state of California.
Great. Thank you so much for sharing that. We have another question here. And this is more on the entry level into LTSS. What types of services are available for folks trying to navigate LTSS? How to make a purchase, decisions on care, decisions on vendors, how they qualify, and where. And I'm going to take an answer to this question here. I'm speaking on behalf of the independent living centers. That's a lot what we do in the initial stages, the INR, the information referral stages. We'll have consumers that'll come to our independent living centers and contact us and say, how do I find an in-home health care worker? How do I find or they go to our counterpart, area agency on aging? You know, where is the adult day healthcare programs in my community? And so being that embodiment of that whole concept of no wrong door, which we always been sharing with the community, is really huge. It gives you that little level of comfort to know that there are experts out there in your communities, in your districts, that can help guide your constituents, to all these multiple levels of care. And Michael, you want to talk about some of the how the intake happens in the AAAs?
Yeah, there are really two formats. There's a traditional kind of information and referral or information and assistance function that points people in the right direction. And then again, going back to the aging and disability resource connections that the independent living centers and the AAAs kind of jointly manage across the state. That's also a more comprehensive kind of referral capability where you actually have options counseling, you actually have some short-term care coordination activities. So you get a more hands-on, warm handoff, kind of a more intense experience. So there are these, and then there's also just 2-on-1 lines and that some people call. But so there are a range of options and a range of vehicles, but the whole idea behind No Wrong Door is to sort of consolidate that effort into one place and then advertise it so people know, because a lot of the problem is that people don't know about these resources that are there right now.
Great. Anyone else want to chime in on that question about intake into LTSS and their communities and what your programs, what your organizations provide? And then we're going to get time for one more final question here. Okay. One final request, we're never getting close to time here, is for all speakers, would each of you be willing to share your contact info via chat for follow-up questions? So there is some homework for or immediate pop quiz for all of our panelists here.
So I don't think we can. It might just be that I am technologically challenged, which is entirely possible, but I can't figure out how to respond to everyone in the chat. So maybe Maria can share our contact information when she shares slides with folks that attended. That would be my question. I'm getting a thumbs up from Liz. Thank you. All right. Yes.
Happy to do that, Debbie.
Can I just say I love the question. I think all of us are here because we want you to see that we're experts and in what place and space we are experts so that you can come to us, because the policy is in front of you. You have the master plan for aging. You can see CalAIM. You can read and research any of that. But if you want to talk to somebody who knows what it's like in real life and in real practice, then we are here for that. So thank you for that question.
Great. I think we are at time here. I want to thank everyone for all your participation, and I hope you come away with a broader understanding of LTSS, what it means for you and your families and your communities. So again, please shout out to our friends at Maria for hosting here, and the California Collaborative for Long-Term Services and Supports, and the SCAN Foundation for hosting this event.
Thank you so much, Dan. I appreciate you being such a fabulous MC. And I want to just close this out with a couple of thoughts. I see folks are still exchanging information in the chat, so we'll keep that open while we close out. When I do close Zoom, you all will see a pop-up, and the pop-up will ask you to provide some feedback on this session. I just want to share that we take that seriously. We look at your feedback. We try to structure our educational opportunities around the feedback that we receive. Just us sitting around, we do this all the time at the collaborative. We get together in meetings and we talk shop and we talk policy. So these are really not for us. These are for you, and we want to make sure that they bring added value. So let us know if there are topics you want us to explore, if there's anything we can do to help you move along and be, partners in this legislative process. process in this legislative year. In addition, I know there was questions around LTSS financing that were a little deeper than we intended to get today. For legislative staff that are joining us, I just wanted to give you a heads up that we are planning some deep dive lunch and learn sessions later this year. We haven't announced dates, we haven't set them yet, but we'll certainly be reaching out soon to see if you're interested in joining us over some lunch and talking shop and meeting some folks who are really experts in their particular field. So keep your eye out for that. And certainly I will not hesitate to email you and bug you about that when the time comes. Really appreciate your time. Thank you for joining us. And I hope you have a wonderful rest of your day. And thank you to our amazing lineup of speakers. You guys are excellent in every way. And I know you took time out of your busy days to come join us. So really appreciate that. Thanks, everybody.